All right, folks, welcome back to Discussions with Dr. G. I'm Dr. G, resident nurse nerd, and your sarcastic usher through the wild world of seizure disorders. So let's kick things off with the basics. What exactly are we dealing with here? Seizure disorders are those sudden, dramatic bursts of abnormal brain activity. Think, your neurons just decide to host a rave without asking you first. Or maybe that's too generous. These parties can mess with your awareness, make your muscles twitch, or cause full-on convulsions. Let's just say, not ideal. Now, there are two big categories. We have focal seizures, which are kind of like the brain equivalent of that neighbor who only blasts music in one room. Focals are localized, sometimes with an aura, sort of like you smell toast or hear a weird sound before things go wacky, and you may or may not lose awareness. Then there's generalized seizures. Those are your full house parties. They kick off in both hemispheres and often wipe out consciousness. Tonic-clonic, absence, myoclonic. That alphabet soup of possible types. Let's not forget about one of the scariest neurological emergencies out there. Status epilepticus. Basically when someone's seizing and just won't stop. Or they snap out of one seizure only to get hit over the head with another with no time to recover. If we can't halt it quickly, there's a real risk of brain damage or worse, death. Time is absolutely brain in these moments. So why does this happen? It's all about that neurotransmitter balancing act. Too much glutamate, your excitatory chemical, and not enough GABA. That's that calming neurotransmitter. And your brain's wiring goes nuts. All it takes are a few triggers. Skipping sleep, chugging too much caffeine, electrolyte imbalances, maybe a nasty infection or missed meds, or binging on substances you really shouldn't. And let's be honest, sometimes life just wants to keep you humble. I'll never forget this moment in nursing school. I walk into the day room and I see a patient stiffen, then drop straight into a tonic-clonic seizure. My brain kind of froze for a split second, but then memory took over. Clear the area, get the patient on their side so they don't choke, loosen anything around their neck, make sure the bed is low just in case they roll, and for the love of all that is scientific, don't ever try to jam anything into their mouth. The first time you see it, your adrenaline goes through the roof, but honestly, having a plan helps you to act instead of panic. All right, that's the crash course in seizure basics, but what about stopping the party once it gets started? That's where medications come in. So let's roll right into the pharmacological stuff. First up, we have sodium channel blockers, the backbone of seizure management. These are your classics: phenytoin, carbamazepine, and lamotrigine. These guys work by blocking those voltage-gated sodium channels, meaning neurons can't just fire off like it's New Year's Eve every 5 minutes. This keeps the electrical chaos from spreading, but they don't come without drama. Steven Johnson syndrome, that rare but terrifying skin reaction, can turn up in lamotrigine and carbamazepine. There's also hepatotoxicity, bone marrow suppression, and don't even get me started on birth defects, especially with phenytoin. So let's break them down a little bit more. Phenytoin, classic. It's effective for generalized tonic-clonic and focal seizures, but here's the catch. It has a very narrow therapeutic window, 10 to 20 micrograms per milliliter. And you need to know that. Miss it, and you can say welcome to gingival hyperplasia, hyperglycemia, confusion, or worse, cardiac arrest, especially if you push it by IV too fast. I always say don't go wild with your doses. Phenytoin doesn't like surprises. Now, carbamazepine, also amazing for tonic-clonic, focal, and even trigeminal neuralgia, not just seizures. It also has a narrow therapeutic window of 5 to 15 micrograms per milliliter and can also lower sodium to the point where you'll be wishing you asked for a basic metabolic panel sooner. Oh, and don't forget the CYP drama. So grapefruit juice is a definite no. And carbamazepine lowers contraceptive effectiveness as well. Now, here's where it gets real dramatic. There's a potential for Stevens-Johnson syndrome, right? I mentioned that earlier. This is a rare but severe skin reaction that causes painful blisters and peeling of the skin and the mucous membranes. It can also lead to organ failure and death. It's no joke. Oxcarbazepine is carbamazepine's less problematic cousin. Fewer drug interactions, works great for partial seizures, and you can use it in kids as young as 4. But it can still tank sodium, and if you're allergic to carbamazepine, don't even try it. So lab monitoring, tracking mood, checking sodium. Did I mention sodium already? Okay. Now let's talk about calcium channel blockers. These work by binding to the alpha-2 delta subunit of the presynaptic calcium channels, ultimately chilling the neuron out by reducing the release of those excitable neurotransmitters. Pregabalin is a prime example. Good for focal seizures, neuropathic pain, anxiety. Most common complaints? Dizziness, blurry vision, weight gain, and edema. Serious stuff includes rhabdomyolysis, thrombocytopenia, and again, risk for Stevens-Johnson syndrome. This drug's also got a little street value, so you gotta watch out for misuse. Plus, you absolutely cannot just stop at cold turkey because withdrawal, no joke. Ethosuximide is a biggie for absence seizures. It's pretty much the only place you're going to see that one used. Gabapentin also lands in this camp. Although gabapentin's got so many off-label uses, it probably needs its own reality show. Again, these meds reduce calcium influx, so the brain can't just rapid-fire signals willy-nilly. What do you watch for? Sedation, dizziness, edema. So if your patient's shoes suddenly don't fit, check their med list. All right, that's the sodium and calcium channel crash course. Not so scary, just a million things to keep in mind. But wait, there's more. Let's talk about GABA, everyone's favorite inhibitory neurotransmitter. GABA augmenters like valproate, valproic acid, topiramate, and phenobarbital. These are the heavy hitters for broad seizure control and also the ones that make neuropharmacology exams universally hated. If you see valproate or valproic acid, think comprehensive coverage. Works for generalized, focal, absence, and mixed seizure types. But with great power comes some very annoying side effects. GI upset, weight gain, tremors, pretty significant sedation. Not great, but usually very tolerable. Until you get into the super serious stuff like the hepatotoxicity, pancreatitis, and in the case of vigabatrin, you heard it, vigabatrin, possible permanent vision loss. Okay? No one wants to trade seizures for permanent vision loss. Valproate can mess with the liver, increase ammonia, lower your platelets, and cause neural tube defects if given during pregnancy. So you absolutely have to check LFTs, ammonia levels, CBC, and screen anyone who is of the age of getting pregnant. Talk about contraception. This is not a try again next time conversation. The wrong call and you could change someone's life, and not in a good way. So let's talk about rescue meds. Think benzos, lorazepam, diazepam, midazolam. These are rock stars when you need to shut a seizure down now. Fast acting, they potentiate GABA, but also the ultimate double-edged sword with respiratory depression. If you're giving benzos, you're watching their airway and breathing like a hawk. Tolerance and dependence can develop, so these are just a break the glass in an emergency situation drugs. Definitely not for long-term use. Side note on lorazepam, This is a go-to for status epilepticus because of its rapid onset, whether IV or IM. And it's also an adjunct for some seizure types, but the sedation is real. I get asked a lot, when should you talk to patients about birth control? The short answer, pretty much any time you're handing out carbamazepine, phenytoin, or valproate. The answer is going to be to use backup pregnancy prevention methods. These enzyme inducers can make birth control less effective. Also, the question, can I just stop taking that? The answer is absolutely not. Abrupt withdrawal can worsen seizures, so you're always going to taper, always educate. All right, if you're still with me, props, because here's where nursing really shines. Management isn't just popping pills and hoping for the best. First, assessment is everything. Which seizure type are we dealing with? Is there some obvious trigger like missed medication or, I don't know, someone binge watching reality TV at 3 a.m. again? Adherence is at the top of this list because even one missed dose can push a patient into status epilepticus. Drug levels matter. Phenytoin, carbamazepine, valproic acid, they all need monitoring like a cat needs a sunny windowsill. Watch for side effects, both the well-known and the weird ones. And remember, abrupt withdrawal is a real thing. It is a giant flashing neon nope. These can actually trigger rebound seizures or status epilepticus. Sometimes patients think, hey, I feel better, let's stop everything. That is a definite hard pass. Safety, always number one. Seizure precautions are more than just orders in the chart. Make sure the bed is low, the rails are up, oxygen and suction are on hand. Airway is the big thing. A tongue can't actually be swallowed, but it sure can block the airway if you're not careful. Oh, and never, ever put anything in the mouth unless, you want broken fingers or a dented wallet. It's just not scientific. Education time. My fave. I like to role play this with my students. You walk into the patient's room, okay? The family is stressed out. Dad's on new meds. He can't drive. He feels like he's lost his independence. It's your job to explain. We need to stick to the medication schedule like glue. Abrupt stops are not an option. If anything weird pops up, a rash, yellow eyes, unexplained bruising, you need to call us. You talk about lifestyle, sleep, hydration, trigger management, and the whole not driving thing. That one stings, but it can save lives. And please remember, each state's laws are different. So you need to check on the specifics for where you live. At the end of the day, nurses are the glue holding all of these moving parts together. We get to monitor, educate, advocate, and occasionally play detective when things go sideways. That's what makes neuro so challenging and also kind of thrilling, if you ask my opinion. Anyway, that's enough for today's trip through the seizure world. Until next time, don't forget safety, science, and just a little bit of snark. Catch you next episode.